MR-guided focused ultrasound ablation can non-invasively deliver a lethal thermal dose with a very high spatial precision. This results in coagulative necrosis, and that's typically thought to pretty quickly restrict the diffusion of molecules into the ablated region. However, the ability to actually deliver small molecules such as chemotherapeutics as an adjunct to ablation has the potential to increase treatment efficacy, especially where there are sensitive regions and you may have incomplete ablation due to wanting to leave margins around the tissue. So thus our goal for this study was to evaluate the extent to which small molecules can be delivered following ablation. What is the time window, perhaps? We chose to use a small molecule, gadoteridol, since we were set up to do a lot of MRI work. So our animal model, I won't go over it too much in detail again. This is the third time you'll hear it, but it's a breast cancer model, syngeneic orthotopic in the mouse. And I've gone over, I think, some of you've probably heard about the circle ablation here, but if we could play the video, I'll give you a little video of the circle ablation, since perhaps you're mostly used to seeing single spots or spiral ablations. So in brief, what we did is we injected gadoteridol either before or after ablation with using either intraperitoneal or intravenous injection to kind of eliminate possible effects of edema or other forms of accumulation. And then following ablation, we imaged at 5 minutes, half an hour, 1.5 hours, 3, 6, and even 20 hours to kind of follow the time course of the accumulation of gadoteridol. Okay, I think that's done. Okay, so we found that accumulation starts within minutes post-ablation, and within 5 minutes you can already see the gadoteridol kind of leaching into the area around the rim of the ablated region, as seen in that image below. But the biggest change comes several hours later when there's a substantial accumulation not just in the rim, but also within the entire ablated volume of the tumor. There was no accumulation observed for animals that received gadoteridol but did not receive ablation, either at 5 minutes or at 3 minutes. So this leads us to believe this is not an effect just of the normal tumor vasculature. And likewise, there's no enhancement seen when animals are ablated, but they're not given gadoteridol, so this isn't necessarily something that's occurring due to edema from the ablation procedure itself. So one possible mechanism for this is loss of cell-to-cell adhesion in regions adjacent to the heat-fixed tissue. As seen in the histological section below, the dark pink is the heat-fixed tissue caused by the ablation, and the surrounding lighter areas, you can see loss of cell-cell adhesion and integrity. Another contributing mechanism may be the dilation of the vasculature, in the immediate surrounding viable tumor tissue. So you can see with this white arrow here, that's a dilated blood vessel within the viable tumor. And on this side is the non-viable tumor. But you can see with the black arrow that there has been some extravasation of the red blood cells. So another possible mechanism for the small molecules getting out of the vasculature and into the area around the heat-fixed region and ultimately within the heat-fixed region itself as that loses its cell-cell adhesion. We found that the accumulation of the gadoteridol post-ablation peaks at 1.5 hours, but the effects last up to 6 hours. And you can see that it gradually starts at the rim, gets perhaps pushed in by inflammation, and then as the cell-cell adhesion is lost within the focal volume, it diffuses into that area. And then ultimately, it diffuses back out. By 20 hours, we've seen it's no longer within the volume it's no longer within the actual ablated treated volume. And this is verified when we re-injected gadoteridol at that time point, and none of the tumor enhanced, suggesting the vasculature of the tumor is, at this point, probably closed off completely. So in conclusion, we found the small molecule gadoteridol accumulates within the ablated volume, the effect peaking at 90 minutes and lasting up to 6 hours, but completely disappeared by 20 hours. So this suggests it's pretty promising that small molecules can be delivered to tumors post-ablation, and we've seen this in both epithelial and EMT mammary adenocarcinoma models. And thank you again for listening, and thank you to Kathy Ferrara and the group and the funding sources.
Any questions? If you have any, step up to the microphone while we'll finish here at the end of the session. It's been a great session. This whole process, it speaks to the importance of having the imaging surrogates to inform the physiology and the biology of what's happening as we perturb the tumor environment. And having these models and some of these imaging tools to optimize things is very cool. I like to split it up into what the information is doing and how it's going to help us to combine things better in a specific clinical paradigm in a specific organ, but we always oversimplify. And I think keep in mind that radiologists who will be interpreting images on patients with some of these therapies down the road have a simple binary process in their brains right now. No enhancement, dead. Enhancement, still viable. And it's very simple interpretation. And what we're seeing in the clinic now with some of these new paradigms with RF ablation, thermal ablation plus checkpoint inhibitors, for example, in the clinic, we're seeing some weird features as the dynamic process happens. It's a very dynamic process. It depends when you take your picture, and things change over time. This stuff with washing in and staying in for a while and then washing out, when does that enhancement happen is different for every organ. But back to the immunotherapy ablation combination in clinic, it's not as simple as we think about it as clinicians. No enhancement, dead tissue, you're done. It's much more complicated. It's not just geometrically putting the tumor next to where you've treated and saying you're done. So with the immune checkpoint inhibitors, we're seeing during the process some peripheral enhancement that may be an inflammatory process adjacent to your treatment zone that may or may not have to do with where the tumor is. With thermodox and RF ablation, we typically see a rim of activity that's active on PET for typically weeks and sometimes months after an ablation. It's not tumor. By all strict criteria, radiologists think it's tumor, but it's just this dynamic process. So these tools are super cool. There's a lot to learn, and I'm glad that some of these preclinical tools are going to inform us, because we've got a lot of education to do on the other end of things as it gets translated.